This concept video will review the pathophysiology of adrenal insufficiency. Now that we have a strong foundation in the physiology of adrenal steroidogenesis and the hypothalamic pituitary adrenal axis, we can dive into the pathophysiology of adrenal insufficiency. The term adrenal insufficiency refers to a syndrome whereby the specific diseases that cause the syndrome are subtyped as either primary adrenal insufficiency, referring to the adrenal glands as the source of the pathology, or secondary adrenal insufficiency, referring to the hypothalamus or pituitary as the source of the pathology. In primary adrenal insufficiency, both adrenal cortices have either been destroyed or rendered non-functional. Therefore, given the inability to synthesize adrenal steroids, both cortisol and aldosterone will be deficient. In the absence of cortisol, there is a lack of negative feedback to the hypothalamus and pituitary, and as a result, a marked upregulation of CRH and ACTH release. However, despite this high ACTH stimulus, the adrenal glands do not respond. Thus, the laboratory characteristics of primary adrenal insufficiency include a very low cortisol, a very high ACTH, and because aldosterone is very low, patients may have significant hyperkalemia, hyponatremia, and intravascular volume depletion. The clinical manifestations are not subtle, because these patients tend to present in a critical or very ill manner. Patients may describe progressive fatigue, lethargy, and anorexia. They will have low blood pressure, orthostatic hypotension, and will be craving salt. Further, they may be significantly hyperpigmented and losing weight. The hyperpigmentation is owed to the high melanocyte-stimulating hormones activating dermal melanocytes and the high cross-reactivity of ACTH with melanocyte receptors. If a cosentropin stimulation were to be performed, the adrenal glands would not respond well in primary adrenal insufficiency. An example of the pathognomonic lab values is illustrated here. Here we see a very low cortisol and an appropriately elevated very high ACTH, however, a suboptimal cortisol response to cosentropin. The causes of primary adrenal insufficiency include autoimmune adrenalitis that may or may not be associated with an autoimmune polyglandular syndrome, or any condition that destroys both adrenal cortices, such as bilateral fungal infections, bilateral hemorrhage, bilateral infiltrative malignancies, and of course bilateral surgical adrenalectomies. In rare cases, antifungal medications, heparin, and etomidate may cause primary adrenal insufficiency by impairing steroidogenesis. In secondary adrenal insufficiency, which we will subtype as either acute, meaning the pathology has been present for days or for weeks, or chronic, suggesting that pathology has been present for weeks or months, the pathology is at the level of the hypothalamus or the pituitary. With a pathology at the level of the pituitary such that ACTH production is deficient, and since cortisol is entirely dependent on ACTH, even though the adrenal glands are perfectly healthy and capable, there is no cortisol synthesis. Thus, the pathognomonic laboratory characteristics include a low basal cortisol paired with an inappropriately low ACTH. Some patients may be hyponatremic. However, since aldosterone regulation is not dependent on ACTH, potassium homeostasis should be unimpaired. The clinical manifestations in secondary adrenal insufficiency depend on the degree of stress a patient is facing and the relative deficiency of cortisol in that degree of stress. Thus, manifestations can range from almost no abnormalities to mild, moderate, or severe signs of fatigue and orthostasis in situations of high physical stress. Since the adrenal glands in acute secondary adrenal insufficiency are intact, in response to exogenous cosentropin, they are expected to display a robust cortisol secretion. An example here shows a low basal cortisol and an inappropriately low ACTH, but a robust stimulation to cosentropin, all supportive of an acute onset secondary adrenal insufficiency. However, if the deficiency of ACTH should continue for weeks or months, over time the adrenal cortex will atrophy since ACTH is a trophic factor. In this context, exogenous cosentropin will yield a smaller and smaller and eventually absent cortisol response to cosentropin, as seen in this example of chronic secondary adrenal insufficiency, where there is a low basal cortisol and an appropriately low ACTH, but a suboptimal stimulation to cosentropin. Secondary adrenal insufficiency can be caused by any insult or injury to the hypothalamus or pituitary, which can include infiltrative tumors, infections, or radiation to the pituitary. However, among the most common causes of secondary adrenal insufficiency are medications, most notably glucocorticoids, which can bind to the hypothalamic and pituitary glucocorticoid receptor and suppress the entire hypothalamic pituitary adrenal axis. In terms of treatment, if you understand the physiology and pathophysiology of adrenal insufficiency, the treatment is logical. For primary adrenal insufficiency, patients require treatment with both glucocorticoids and mineralocorticoids to replace their deficiencies, whereas for secondary adrenal insufficiency, patients require only glucocorticoid replacement to replace their deficiency.